So the way this is going to work is I'll give you a bit of a stem. So here we have a 58-year-old man with weakness. And now I'm that man, and you ask me questions about this weakness, and I will give you more information, and then we will stop and see if we can localize this man's problem. Okay? So I need your help with this. So I'm in your surgery now, and you're going to ask me some questions. What would you like to know?
Did it come on suddenly?
Did it come on suddenly? No, it came on over a couple of weeks.
Where?
My right side, my right arm is weak. Right arm, sorry. I can't, it's very small. Yep.
Any double vision?
Good question. No double vision. No double vision.
Do you remember how it started?
What do you mean by that?
What were you doing? What happened?
No, I don't remember about how it started. I just started noticing it, and then it started getting worse.
Where is it?
My right arm?
Do you have any other symptoms?
You have to be more specific than that.
Any numbness?
Yep, I do have some numbness that's also been building over the last couple of weeks in the same limb, right arm.
Any history of trauma?
No history of trauma.
Headache?
Yes, funny you ask. I do have some headaches.
Whereabouts?
Oh, just all over the head.
Do you normally have headaches?
I don't. This is kind of a new thing.
What's your blood pressure?
I don't know what my blood pressure is. You're my doctor.
May we take your blood pressure?
You may, but you're not going to find out what my blood pressure is. So you're still talking to me at the moment. So 58-year-old man with right arm weakness and numbness that started a couple of weeks ago, and some headaches. Do you want to know more about the headaches? What do you want to know about the headaches?
Are they getting worse or better?
They are getting worse.
What makes it worse? Coughing, sneezing, going to the bathroom?
Not that I've noticed any of that, no.
Have you been taking any medication for the headaches?
No.
Do you wake with a headache?
Hmm?
Do you wake?
I do wake with the headaches. Yeah, I wake up early in the morning, and then they get better over the course of the day.
Any vomiting?
No vomiting, but I have been a bit nauseated in the mornings. Any other symptoms you might want to know about?
Do you have any tingling or pins and needles?
No pins and needles, just numbness.
Any pain?
No pain, well, other than the headache. Yeah, no pain.
Any fevers? Any feeling unwell?
No, otherwise feeling pretty good.
Any weight loss?
No.
Any strange movements or shaking?
No strange movement or shaking, but my wife said that I had a couple funny turns where I was moving my mouth or something like that, but I don't really know what she's talking about.
Have you used medication?
No.
Is there any family history of epilepsy?
No.
Have you had lung cancer or anything like that?
Um,
Other illnesses?
No, I do smoke, but I haven't had any lung cancer. So why don't we stop here? Now, what are you thinking? Now think localization first. Don't think making a diagnosis. Where do you think this problem could be? So you're thinking in the brain. So let's what we'll do with these exercises. Well, could it be? Let's walk through it. So you're thinking it could be in the brain. Let's actually move from the other side. Could it be in the muscle?
No.
Why not? Numbness. Very good. You listened. What about the neuromuscular junction?
No.
Because of same reason, numbness. What about peripheral nerve? It wouldn't explain the headaches and maybe not the funny turns, but anatomically, we've got numbness and weakness in an arm. It could be a peripheral nerve problem. Right? We haven't examined that arm yet. What about a plexus problem? Could be. What about a nerve root problem? Yeah, could be for the same reason. You have sensory and motor fibers running through the nerve roots, so it could be would have to get both, but that happens. So what about spinal cord? Well, ignore the headaches for the moment. So people get headaches all the time, so you have to be prepared that it could be two separate things. So you're thinking less likely spinal cord because you kind of focus already on the head because of the headache, but could it be purely on the numbness and the weakness? Could it be spinal cord? It could be. What's unusual about it?
One side.
One side, and what else? If you have
Just the arm.
Motor and sensory. If you're getting motor and sensory on the same side from a spinal cord lesion, which some sensory fibers do run on the same side, right? But what's missing if you have a big spinal cord lesion? Where would the spinal cord lesion be?
Oh, it would be high.
High, right? It'd be cervical, right? Because it's getting the arm. If you have a big cervical cord lesion, what would you expect also? Legs, right? Because if you're cutting off the spine at that level, everything below that should be abnormal. Does it happen? Sure, you can get it, but it's a little bit unusual, right? So you would expect some leg, like stiff gait or some other problem. So people with cervical discs tend to have maybe a bit of even some peripheral symptoms, like a radicular pattern, and then gait problems. They get stiff legs or shuffling gait, things like that. But it could be just the arm. All right, so moving up to the brainstem. What about the brainstem? Could be. So it's a bit unusual for a brainstem because we have no cranial nerve involvement, right? And it's just the arm. And in the brainstem, we're dealing with tracts. And when tracts are damaged, just like with the spinal cord, we tend to see more of a hemi-body or more diffuse problem. So it's not that easy from a brainstem perspective to get just a mono-limb problem that's both sensory and motor. By the time you get both motor and sensory fibers, you're more likely to also get a bit of leg in there and some cranial nerves because they're not in the same place, right? Sensory and motor fibers are two different fibers, two different tracks. And we have no other cranial nerve involvement at all. So it could be, but it's less likely. Kind of like the spinal cord is a little bit less likely. So we're thinking maybe an arm problem, something from the nerve root down, or now we're moving up. What about the cerebellum? Why not? Sensory symptoms, right? What about the basal ganglia? What about the thalamus? Now, I do always say the thalamus can do everything, but based on what I taught you this morning, does it seem likely? No, because of two things. One, you have sensation and motor problems, and it's also just the arm. I was talking, those deep nuclei tend to affect things equally sort of across. So, okay, now we're moving up into the other basal ganglia. We've got sensation. It's a little atypical. We would expect just motor problems. So we're moving to the white matter. It's possible, right? You can get things together like the internal, external capsule. Again, a little bit less likely because you're only involving the arm. So you're much more likely to be kind of out in the periphery where you're getting a part of the homunculus. But then you're getting sensory and motor. So, you're kind of like, well, nothing fits 100%, but I've narrowed it down. I don't think it's the spinal cord. I don't think it's muscle. I don't think it's neuromuscular junction. I don't think it's the brainstem. I think it's somewhere supratentorial, probably peripheral more than deep central. And maybe I'll just keep an open mind about a monolimb problem that's in the periphery. Now, you're moving into the examination. And you've also keep in the back of your mind your other historical features, which have already pointed you towards what? The brain because of the headache. What else? The funny turns. What do you think those are? Seizures, okay. So you're thinking it's probably in the brain because of those associated features. It fits with your localization reasonably well, but you're just thinking, well, maybe there could be two things, and I won't dismiss completely the arm. So what are you going to examine? So you're going to examine the arm, right? Yes, there is some weakness and some numbness. It's affecting the entire arm. And what else would you like to examine? Reflexes. Why do you want to look at reflexes? Perfect. So you're doing reflexes to tell whether it's upper or lower motor neuron. If they're high, you're confirming your pretest diagnosis, which is a brain lesion. If they're absent compared to the other side, you're thinking, maybe it is a peripheral problem. So this particular chap has hyperreflexia and a Babinski sign on the right side compared to the left. What else would you like to examine? Cranial nerves. So when you look closely, there actually is a little bit of a subtle facial droop on the right side. And what else would you like to take a closer look at, given this headaches that he wakes up with? You want to look at his optic discs. And you look in his optic discs and you see just a hint of papilledema. Okay? Just a hint. Because you're really good. You see some optic nerve disc swelling. Or you think you might. Or you might send them to an optometrist. Okay, so now what you're thinking. So now you've got this man who has a couple weeks of progressive numbness, weakness, a couple funny turns, and what you think is a brain lesion. What test do you want to get? CT. If you're in my world, you're getting an MRI. And so you have a brain tumor on the left side. And it's frontal, but it's a huge amount of edema catching a bit of the parietal area, and it's quite peripheral, so it's sparing the leg and primarily affecting the arm and the face. So it's almost like an MCA territory motor lesion, more weakness than numbness. And he's got a bit of edema, and that's why he's got the headache and the papilledema. Okay, here's just another example of brain tumors. On MRI is a different tumor, and these look a bit like metastases. So it's good somebody asked about smoking history, other risk factors. So this would be consistent with a MET from a lung lesion. So this is bread and butter for you, so you do this all the time. I did want to talk about it a little bit because headaches is the most common source of phone call we get. Even though we don't manage a lot of headaches in the public sector as an outpatient, we get a lot of phone calls from GPs about headaches. So just to review, what should make you worried? So obviously if you have subarachnoid hemorrhage is what everyone worries about, right? So sudden onset of severe headache, worst headache of your life. Now, that's pretty easy to spot, right? You have somebody like that, they don't even come to you. They usually go straight to ED. What you get is the person with a really severe headache that is new and is gone, right? You get them, you worry about that sentinel bleed, don't you? Because I get those calls all the time. Could this be a sentinel bleed, a warning sign of a subarachnoid that's now stopped? So sentinel bleeds, they usually do last more than an hour, not instantaneous. And really concerning headaches don't go away. So sentinel bleeds are pretty rare. So we did an audit. I gave a lecture to students, and one of the students was asking, well, how often do people present with a sentinel bleed and then develop a headache? So there's very little data on that. We have people have subarachnoid who present with subarachnoid going back how many had something that might have been a sentinel bleed. There's not a lot of data out there about how many people show up with the people you see who then turn into subarachnoid hemorrhage, which is a slightly different question because your pretest probability is much lower than if you already look at people who've had subarachnoid hemorrhage, because those we don't want to know because they already have the subarachnoid. It's pretty useless to know how many of those have had a sentinel bleed. You want to know of the general population, people with really severe transient headache, how many have a subarachnoid hemorrhage. So we audited some 500 people presenting to Wellington Hospital with, and we had a Palmerston North cohort as well with GP scans, and we didn't find anyone. We found nobody who presented with transient headache who ended up having a head scan. So these were the subgroup of people who people were concerned about, right? People like you thought, oh, something isn't quite right. I'm going to send them to ED, or I'm going to get a community referred scan. None of them had subarachnoid hemorrhage. Now, some people did have bad problems, but those were almost all people who either had persistent headache or who had some focal neurological sign or symptom. So something, numbness, weakness, visual blurring, something focal neurological. And the pickup rate, and usually they were strokes. Usually they were actually ischemic strokes, more than you might think hemorrhagic strokes. So ischemic stroke was the most common cause, a common problem we identified on the series that was picked up incidentally because people had a headache. But there were a few hemorrhages and there were a few brain tumors, not many. So you don't dismiss it. You do, if you have somebody with my man here with morning headaches, red flags such as certainly neck stiffness, rash, decreased level of consciousness, all that. That's pretty easy. But somebody did ask about coughing, Valsalva. You do want to ask about those things about increased pressure. You do want to ask about visual changes. I'm not sure anyone asked me about visual changes just now, but maybe they did. Okay, so visual changes are important to ask about. Blurred vision, visual loss, diplopia somebody asked, so it's just a little bit different. And then associated neurological symptoms, gradual worsening over time, and if the person is over 50. So those are really the worrisome. The calls I get are often about exercise-induced headaches or coidal headache. Those are the questions I get because there's concern that is that a subarachnoid hemorrhage. So it's exceedingly rare. So coidal headache and exercise-induced headache are not uncommon. And the other key piece of information about a sentinel bleed, now we didn't find any, so we couldn't really develop any kind of algorithm as to what should make you worried. But if you look at the literature, at those people who had subarachnoid hemorrhage and then had historical recall of a headache, the subarachnoids always occurred within 2 weeks of the headache. So if somebody's had a headache 3 weeks ago, a brief, severe headache, or if somebody's had recurrent coidal or exercise-induced headaches that go away for a number of weeks, it's not subarachnoid hemorrhage. So, so that's the best I can tell you. Obviously, there's always going to be some baseline risk, and I don't want to minimize it completely, but the vast majority of people do not have this if their headache resolved. So the next patient is a 34-year-old woman with worsening headaches. What would you like to know?
When did that start?
About 3 months ago.
How often did it happen?
At this point, it's daily. Over the last 3-4 weeks, it's been daily, intermittent before that.
What medication is she on?
I'm taking some Nurofen.
Daily. Is it good?
Well, at this point, daily, because it's there every day.
So you're not on an oral contraceptive or change?
I'm not on an oral contraceptive, no.
Do you have visual changes?
I do not have visual changes.
Is she waking in the night with the headaches?
I don't wake at night.
Where are they located?
All over,
Do you have
but sometimes a little bit more on the left.
any associated neck symptoms?
I have occasional sort of stiff neck. It hurts back here.
Do they vary in intensity?
Yeah, they do. When I take my Nurofen, it gets a little bit better, and then it gets worse again.
What's
Is it
been
most-
happening in your life over the past 3 months? Work and family?
Nothing out of the ordinary, really. I mean, my boss is always a pain, and since I've had the headache, it's harder for me to deal with it. I'm a little bit stressed about the headaches. I'm really worried that I have a brain tumor, but other than that, things are going okay.
How long do they last for when you have them?
They're there all the time now.
Constant.
Constant. Just fluctuate in severity a little bit.
History of head injury or neck injury?
No history of neck injury or head injury.
Do you have weakness?
No, I haven't had any weakness.
Or numbness?
I have had a little bit of tingling in my lip and my right arm.
Any family history?
Of migraines? Well, my mother gets headaches occasionally, but she's never been diagnosed with migraines.
Do you have any runny nose or eye symptoms?
No.
Is the thing when related to headache, does it happen before, during, or before?
Well, I have the headache all the time, and I sometimes get the tingling. I don't know, maybe maybe when the headache gets worse, but I'm really not sure. It's sort of all one big blur now, and it comes and goes.
Any nausea or vomiting?
I have had some nausea. Yeah, no vomiting. So what are you thinking at this point? Before we finish the history. So you're thinking some kind of benign-ish headache syndrome. So if you want to tease that out more into a particular category, what questions might you ask?
Sleep okay? Stressed?
I'm a little bit stressed because of my boss and because of the headaches. I generally don't sleep well. So if you're thinking, you're thinking tension headache, what's your differential diagnosis? Migraine. So if you're thinking migraine, what questions would you ask?
Triggers? Triggers?
Triggers? And you said? Aura?
Sound and light.
Photophobia, phonophobia. So triggers, and then I'll tell you now that I've had headaches since I was in my 20s, episodic, and those would often be triggered by not eating, or sometimes I really cannot drink red wine. Chocolate is a real problem for me. So I have some triggers, and I do get light sensitivity and noise sensitivity. Would you like to know what I do when my headache gets really bad? It's a really important question to ask. Some people get better with activity. What do MIGRAINEURS do? They get worse with activity. So when my headache is really bad, I go lie down in a quiet room with the curtains pulled. If you hear that, you almost certainly have a migraineur on your hands, right? So the other thing, there's a few other things that you could ask for. Actually, I'll get to that in the next slide. But the other thing that in my particular case is it gets worse with when I drive in the car, in the back seat. This headache gets really bad, and I feel really nauseated. Okay. Now let's step back. So we're thinking it's some kind of headache thing. Now, what's the one concerning thing here in their history? The tingling. So let's talk about that a little bit more. So we've got lip tingling and arm tingling on the right side. So what do you want to explore that a little bit more?
Are you breathing fault when you get them?
No. So you're asking about hyperventilation. Now, hyperventilation typically causes bilateral tingling rather than unilateral tingling, but it can be a bit, funny. So no, so I don't hyperventilate, or at least I don't think I do. It's a quite a hard question to ask the patient, but so this particular patient is not hyperventilating. But so you had asked a little bit about when it comes on, and so you might want to just drill more. So now we're in this headache period that's been going on for weeks, so it's hard for her to discriminate that. But it's worth going back to the previous migraines. So what about the migraines between age 20 and 34?
So with medication, sometimes people actually get a constant headache from continuous use of non-steroidal. So if in the past a course of 4 or 5 days worked for her, and now it hasn't, then that might be a sensitivity or tolerance or intolerance to it from now. There's a possibility, but probably not common, I'm guessing.
Yeah, well, and it's a funny thing with medication responsiveness. We blame a lot on whether medications work or not in tolerance, and sometimes it's just random. Sometimes it's just the headache's getting worse, or some other trigger that's been loaded on, or the stress is getting worse. Now, the medications in this particular case almost certainly will have contributed in one way or another, but why they stopped working, it's really hard to. That's not usually a very useful historical thing to know.
Yeah. So would you, as a clinician, add in something to determine that?
Right. So let's talk about management of this in a second. So we're worried about the numbness and tingling right now. Let's worry about that. Let's decide whether this is benign. Can we ignore it or not? So maybe we'll start by localizing it. Okay. So we have lip tingling and arm tingling. Could this be a muscle problem? And I'm doing this partly to exercise our localization skills. No, it's not a muscle problem. Is it a neuromuscular junction problem? No. Is it a peripheral nerve problem? It could be. There's both peripheral nerves, but they're bit funny because it's all on one side and not connected in any way. It could be, but statistically less likely. Could it be a plexus problem? Absolutely not, because the face has nothing to do with any kind of plexus. It cannot be, if you want to link them into one problem and they're occurring at the same time, so that is seems very likely, it's not a plexus problem. How about a nerve root problem? No. Now, so it's a funny thing about the cranial nerve 5. The spinal nucleus does dip a little bit down the cervical cord, so you can occasionally get a little bit of numbness from not a nerve root problem, but from a upper cervical cord lesion. You can get occasionally a little bit of numbness in the chin, but it's rare. But you don't want to dismiss it entirely because of that. So maybe it's upper cervical, but not nerve root problem. What about brainstem? It could be a brainstem problem involving the cranial nerve and a limb. We said earlier it's more likely to get the whole side, but we also said it doesn't completely exclude it. It just doesn't fit so well. What about the cerebellum or basal ganglia? No. What about the thalamus?
Yes.
Yeah, could be tingling. What about the cerebrum? White matter or gray matter? It could be. So it could be, right? Cannot exclude it completely. So what we have is we've localized it pretty much to the brain. Yes? We've excluded nerve unlikely, so we've kind of moved it up here to the brain. So we're thinking it's a brain thing. So that's not really very reassuring, because now you're thinking, oh my God, is it a brain tumor? So that's when you get back to your course, right? So that's when you now kind of start thinking about some things that could be helping you differentiate it further. And the other thing you want to, whenever you talk about numbness, you want to talk about the nature of the sensory feeling. So when you talk about numbness and tingling are two different things. Yes, so numbness is a loss of nerve function. Tingling is a hyperactivity of nerve function. Just like weakness is a loss of function and jerking is a hyperactivity. Chorea is a kind of an activation, but that's a little bit of a tricky one, because sometimes you can get more movement by inhibiting an inhibitory nucleus. So don't worry about the chorea so much. Those funny movements are a little bit in a different category, but you're talking seizure or lack of movement. Seizure is hyperactivity, weakness is hypoactivity, tingling hyperactivity, numbness hypoactivity. And that is of reassurance. So if you have somebody with tingling, you're less worried about that than numbness, because you could have irritation of nerve tissue, which is usually more benign than having loss of nerve function or a damage of nerve tissue. Now, it's not completely always true, so you can have strokes occasionally with some tingling, but generally strokes present with numbness. So this lady has tingling, which is reassuring, and you're thinking it's in the brain in the setting of headache. So you're thinking, well, maybe could this be an aura? And that's when you go back, well, what about your headaches 10 years ago? Did you ever have a headache with this numbness or this tingling? And she tells you, oh yes, I get this tingling every time in the past when I've had a headache. It starts in the lip and then moves in the arm. And then you're like, oh, well, that's it. And it comes over a few minutes, and then I get the headache. So if you established it's a migraine aura, which are brain problems, they do that's because of cortical cortical depression, so blood flow related, and that's fine. So we're happy with that, and we don't need to do imaging based on that. And it's transient. So transient symptoms are always much less worrisome than persistent symptoms that get worse. But having said that, if you have focal neurology in somebody who's new with headaches, it's always good to do an image at some point. But this lady's had it for years, so you're not worried. So let's talk a little bit about her particular syndrome and how we would manage this. So this lady's been using Nurofen for 4 weeks, 3 or 4 weeks, ever since her headache became daily, every day. So she has an analgesic rebound headache, or overuse headache, the same thing, on top of a history of migraine. So she's had a bad episodic migraine, then something happened that we haven't fully identified yet that made her have a 3, 4, 5 day prolonged headache period, she kept taking the Nurofen, it didn't abort the headache, and she got into that analgesic rebound headache pattern. So that's what this lady has. But you want to consider some other diagnoses, and not everyone is quite as obvious as this lady. So she's never presented before. Say she hasn't had a prior history of migraine. You want to exclude some other causes of headache. So I've put some here, and at some point, if it's not a clear history of migraine, it's worth checking a few blood tests. So some vitamin deficiencies can cause headaches. Iron deficiency, these pretty rare, but if you're really not sure, it's just good to tick those boxes and get at least some iron studies. Hypothyroidism, diabetes actually causes headaches. I don't know if you appreciate that, but a lot of diabetics have headaches, and it's because of their fluctuating glucose levels. So poor diabetes, not necessarily in itself, but poor glucose control can cause headaches. Dietary, so dairy and gluten, people who are not necessarily Whipple's disease, but people who have a gluten sensitivity or dairy sensitivity can have problems with headaches. And you often, so I've had a patient once who, as a young girl, 16, who went to boarding school and had these really carb-heavy meals, and every time she had meals, she started getting headaches, and so we removed them, and her headaches were fine. So you know, I do think that looking at diet is really useful. There's some people who think that you start eating chocolate because you're starting to feel like you're getting a headache and you feel depressed about it, and that's why you eat chocolate. That never really made that much sense to me. But so, you know, I think there's a clear correlation with chocolate and people getting headaches, rather than just them eating the chocolate because they feel bad. That sounds funny, but there's some literature out there that suggests that. So I do believe that dietary triggers are important. Anyway, so you can get some allergies. So there's some bad inflammatory things like cerebral vasculitis and those kinds of things, but really rare. So I want you to focus on some of the things you can check for pretty quickly and just exclude them. And do consider sleep apnea. So in bigger people who are a little bit older, sleep apnea is quite a common cause of headache. So do think about that. And then, of course, if multiple household members are presenting with headache, you want to think about carbon monoxide poisoning. So I'm putting these things here because they're all things that you might want to consider. You do maybe want to do some blood tests. Sometimes the patient feels reassured, even if you're pretty sure it's migraine, to do a few blood tests, because the next step is to convince the patient that they have migraine headaches and not a brain tumor. And so it's about winning the trust of the patient and making them feel that you really know what you're doing and you can diagnose this and you don't need all sorts of imaging. So knowing the diagnostic criteria is useful because you can start anticipating some of the symptoms. So here's just to remind you the 5, 4, 3, 2, 1 rule. These are the diagnostic criteria. This lady has had more than 15 headache days over the last month, so she is classified as a chronic daily headache. And then tension type headache. So tension type headache is classified as a different kind of headache. In my mind, they live on a continuum. So people who get migraine headaches get other headaches, and most people who have chronic tension type headaches eventually will get a migraine. So I think there are headachy people and then there are non-headachy people. The headache people who get migraines also are much more likely to get things like hangover headaches, to get the headaches when they descend on a plane. So it's just a lower threshold to get head pain. And I think, to me, they're treated quite similarly, except that, of course, a tension type headache you wouldn't treat with a triptan. That's sort of the main difference. But the prophylactic medications like tricyclic antidepressants work for tension type headaches, non-steroidals work for both. So there's just a lot of overlap, and I haven't found it that helpful in my clinical practice to make this big distinction between the two. Interestingly, sometimes tension headaches are easier to convince the patient of, especially men. Men don't like to have migraine headaches because it sort of has a stigma associated with it. But so this is then the next step. You want to convince the patient that you think they have migraines. And the way I do that is I keep all of these things in mind, because they're often things that migraineurs get. And so you can say, do you ever get sensitivity to light? Do you like wearing sunglasses? Does loud noise bother you more so than other people? Do you ever have the situation where you're in a room and people are talking, and you're talking to somebody else, and you hear everyone else's conversation, but not the one you're trying to focus on. Anyone who's had a migraine knows that feeling, and migraineurs will say, yeah, I get that. That basically they get sensory overload, and they're struggling to filter out unimportant things. Flickering lights. So migraineurs see a flickering with halogen lights. Non-migraineurs don't. So you kind of wow them a little bit, and they go like, yes, 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 I have that. Do they have insomnia? They're light sleepers. They're not necessarily insomniacs, but they'll wake up with again, it's that hypersensitivity thing. They get nausea, motion sickness. They cannot be on boats, they cannot be on trains, they struggle with planes. In the back, can you read a book on the back of a seat of a car? Hardly any migraineur can do that. Again, it's a hypersensitivity issue. It's not psychological hypersensitivity, it's neuronal hypersensitivity. The nerves just fire a little bit faster, and all it is, you're sitting in the car, you notice everything, while the rest of the world is quite fine just reading the book. You're more sensitive to the environment, and you get overload, and that's when you get the headache. It's a little paresthesia, and then you preempt it before she even says she has tingling in her lip or arm. You say, do you ever get tingling in your lip or arm? And they're like, yes. Oh, that's got me really worried. It's like, well, that's all part of it. What about abdominal pains, nausea, irritable bowel syndrome, diarrhea, constipation, or chest pains? Sudden, sharp chest pains. Migraineurs get those. Growing pains. Pains in the calves. There's very little evidence that growing pains have anything to do with growing. They just happen in kids. They sometimes happen in adults. It's a crampy leg pain at night. It helps a little bit if you elevate your legs. More common in migraineurs. It's probably a vascular phenomenon. A bit of dizziness, pre-syncope, vasovagal episodes, a bit of an anxious type B worrier personality. That doesn't mean they have anxiety, generalized anxiety or depression. Don't go down that route because you'll lose them. They're normal people and generally very highly functioning people who are people who, suck in the stress around them and try to solve everybody else's problem. They can run a bit cold as far as basal temperature. There's often a strong family component, GI complaint. Sometimes overlap with fibromyalgia, again, a pain hypersensitivity. So if you kind of just ask these questions and they go, oh, yes, oh, I have that, you're giving them confidence that you know what you're talking about. And you're making that diagnosis and you say, guess what? You are not alone. There's lots of other people who suffer from the exact same thing, and it can be really debilitating, and let's work together to get this under control.